So I'm going to welcome back to the stage Dr. Haley Houston, and then joining her is Dr. Bennett Henderson for our next topic on menopause, hormone replacement therapy, and heart health. So Dr. Houston, welcome back. And joining her is Dr. Bennett Henderson, one of our favorite OB-GYNs with Covenant Medical Group. So, Dr. Henderson, I think you're up first.
Yes, thank you. All right, so we're going to talk about menopause a little bit and how we can help y'all get through that period of life. So there are a few stages of menopause. Pre-menopause is when we are having our menstrual cycle on a regular basis. Our estrogen is increasing and falling at a normal rate. Progesterone is doing a similar cyclic change, and we're getting a monthly predictable menstrual cycle. Perimenopause is anywhere from 2 to 10 years before menopause, so that's a big range, where our hormone changes that should be cyclic are now fluctuating differently, and they can be quite erratic. So we can have changes in our estrogen and progesterone that aren't predictable. And so you may see changes in your cycle becoming irregular. You may have symptoms like hot flashes, night sweats, up until the time of menopause, which is when we don't have a menstrual cycle for a full 12 months. There are other ways to check that. We can order an FSH level, or a follicle stimulating hormone, and if that is over 40, you are overtly menopausal, and if it's greater than 16, you're potentially menopausal. Then we have post-menopause. Menopause typically on average is at age 51, but can have a large range. It can be related to how women in your family have, when they have entered menopause. And so if you had a mother or grandmother with early menopause, you may be at risk of early menopause, and that increases your risk of heart disease and other issues. The postmenopausal range is after menopause, and symptoms can last for up to 10 years. We're going to talk about how menopause affects your heart specifically.
Okay, so estrogen. Estrogen does many amazing things for us. When we lose our estrogen, we can have, estrogen affects the whole body, okay? Not just when we think about it, just like our uterus and our ovaries and all that. It affects within the vessels themselves. So we call, inside the vessels, we have something called the endothelium, or the endothelial lining. That's actually the cells that make up the inside of the vessel. And estrogen works there too. And so when you lose your estrogen, you can have dysfunction with that endothelial lining, and that can cause your blood pressure to go up. Loss of estrogen can also cause your cholesterol to go up, specifically your LDL, that bad cholesterol that Dr. Iskander referred to, that can go up, and the HDL, which is the good cholesterol, can go down. Estrogen also helps with metabolism and with insulin. And when the estrogen levels go down, your resistance, your insulin resistance increases. So your pancreas has to make more and more insulin to get the same effects. And so you can have issues with your A1C going up and becoming pre-diabetic and diabetic. Like I said, estrogen helps with metabolism, so women can have weight gain when the estrogen levels decline, and also losing muscle mass, which is why weight training is so important to help us maintain that muscle mass. You can have problems with hot flashes and night sweats, and also mental health changes. A lot of women, perimenopausal and postmenopausal, will have symptoms of kind of brain fog, those sorts of things. At age 65, women and men's cardiac risk, everything else being equal, is about the same. Now, you get into individual risk factors like high blood pressure, smoking, all that stuff, then it can change. But if you just take a man and a woman 65, the risk is the same for both. Whereas for women, it's lower when they're younger. And that has to do with estrogen, because at age 65, most women are, 10 plus years out in postmenopause.
So, Dr. Henderson, what can women do to manage their menopause symptoms and protect their heart?
Sure. So first of all, we have lifestyle changes, which we've discussed. The nutritional aspect, we also recommend an anti-inflammatory diet, Mediterranean being an example. But we want to emphasize not having added sugars, including fiber in our diet, as well as vitamin D. Exercise, extremely important. Weight-bearing exercise, strength training. If you're like, I am not going to go start lifting weights, like that is not where I am in my life. Wearing a weighted vest, which you can order off Amazon with varying weight levels, just around your house while you're picking up or walking outside, is a simple way to help improve your bone mineral density and also your skeletal muscle mass, to stay strong and help maintain your independence as we age, and stop from being frail. That is one thing we do not want to be.
And it's the new fashion accessory.
Yes.
If you walk in your neighborhood or walk in my neighborhood, all the cool kids are wearing those now.
Yes,
so,
lots of
yeah.
high vis as well.
Absolutely.
Some metallic moments, so that's good. Stress management, things like layering your clothes to deal with hot flashes, having cold drinks with you, having cooling rags with you, and then sleep hygiene, like we've discussed. And then physician support, so coming to your doctor to discuss these symptoms so that we can help you manage them. Counseling and therapy can be an important component of this. The changes in estrogen that we have do lead to mood issues like we discussed, like depression and anxiety, and coping with the symptoms we're having. Cognitive behavioral therapy, or CBT, can be helpful with that. And we would love to plug you in so we can help you cope with all the changes your body's going through. There are non-hormonal medications, so not everyone is going to be a candidate for hormone, and we'll talk about that. But there are options. Antidepressants, SSRIs or SNRIs, are very good at helping with hot flash symptoms. Gabapentin, a medicine that's usually for neurologic changes, can help, as well as clonidine, a blood pressure medication. So you don't have to suffer with hot flashes. Hopefully we can find something that works for you. And then also things like vaginal dryness. We have non-hormonal medications, vaginal lubricants, and moisturizers that can help with those types of symptoms. And then we have hormone replacement therapy. So there are different types of hormones that we replace in our body, but the ones we're talking about for menopause are mainly estradiol or estrogen, progesterone. You need progesterone if you have a uterus. So if you have had a hysterectomy, then you don't need progesterone as a part of your hormone replacement therapy. Estrogen will thicken the lining of your uterus. Progesterone will keep it thin. So if we only give you estrogen and you have a uterus, that is wrong. You should talk to your doctor. Progesterone is a hormone that can slightly increase your risk of breast cancer, and so we always recommend using micronized progesterone or prometrium, because that does not. And then testosterone is something that you may consider, usually for energy or libido issues. For both men and women, we do not need as much testosterone as a man at all, not nearly, anywhere close. And if you do choose to do testosterone replacement, it needs to be with your doctor, with labs every 6 to 12 weeks to make sure we are not overshooting that level. We are shooting for 40 to 70. And if you do not have improvement with testosterone in 6 months, you should get off of it. It does have bad side effects like coarse hair and a male pattern, deepening of our voice, and enlargement of the clitoris. So I would just be mindful that it can be helpful, but it is not a cure-all. Okay, benefits. So estrogen, like Dr. Houston said, we have estrogen receptors all over our body, everywhere. So when we lose it, we get symptoms everywhere. So relief of menopausal symptoms, hot flashes and night sweats is going to be the most common complaint that we hear about menopause, but there are lots of other things it affects. Bone health, we have estrogen receptors on our bones. Replacing estrogen can reduce your risk of osteoporosis and fractures like hip or vertebral fractures. Hip fractures are one of the things that increase our morbidity or mortality quickly, and we can go from being very independent, doing everything ourselves, and then now needing a significant amount of assistance when we experience a hip fracture. So estrogen replacement is important there. Also, our skeletal muscle mass is affected by estrogen, has estrogen receptors. Our cardiovascular health can be improved by estrogen if we time it correctly. So estrogen started within 10 years of menopause can improve our heart health. You'll see later when we talk about risks that timing is the most important part of that. Urogenital health, so vaginal dryness, pain with sex, urinary urge symptoms, recurrent UTI can be related to depletion of estrogen. So if we do topical estrogen to the vagina, we actually recently had a study that showed that postmenopausal women who have a high rate of hospitalization for recurrent UTI and a lot of medical cost, that was reduced by simply replacing vaginal estrogen. Cognitive and mood support. We have estrogen receptors in our brain. So mood, depression, anxiety, mood instability, it can be improved with hormone replacement therapy because we're giving you a continuous amount of hormone. So we're not having this waxing and waning, especially during that perimenopause period where the estrogen levels are so erratic. You may have brain fog, not remembering things as well, feeling fuzzy. Those things can be improved with estrogen replacement therapy. And then studies have found that if you have an increased risk of dementia, that estrogen replacement can actually reduce your risk. Skin and hair benefits, so collagen, the elasticity of our skin is improved. There's also a study that just came out about estriol. That's a different estrogen than estradiol. That estriol creams are very good for wrinkles and collagen production in the face. Improve sleep and energy, mainly because of reducing night sweats, but also that kind of mind racing situation where we feel like we cannot shut our brain off. That can be improved with estrogen, and progesterone can help with sleep as well. And then sexual health, mainly vaginal lubrication and reducing discomfort during sex, but also libido. With all good things, there are risks. So estrogen, especially oral estrogen, can increase your risk of blood clots like DVT in the leg or PE in the lung. Other forms reduce that risk. Stroke is increased with any form of estrogen replacement, and so we need to be mindful about your individual risk factors. Breast cancer is increased when you are doing estrogen and progesterone hormone replacement. So estrogen alone does not increase your risk of breast cancer, and that is why we choose the micronized progesterone, which does not increase your risk of breast cancer. Heart disease risk is increased if we give you estrogen 10 years after menopause. So it is important, especially to talk to your perimenopausal friends, that they start considering the timing of their hormone replacement therapy or menopausal replacement therapy. And then endometrial cancer. If I only give you estrogen and you have a uterus, I can give you uterine cancer over a few years, and especially after 10. So you need the progesterone to balance that out, and then we actually reduce the incidence of endometrial cancer. There are different routes of hormone replacement therapy. So transdermal is through the skin, so you can have a patch, an estrogen patch. You can have a gel or cream for estrogen or testosterone. Orally, you can do estrogen or progesterone. And vaginally, we have estrogen creams, rings, and tablets to help with lubrication and the overall quality of the mucosa. That estrogen also improves the mucosa of the bladder and the rectum, so it really can have benefit through your whole pelvis. And just vaginal estrogen targets vaginal symptoms much better than systemic estrogen. And you are allowed to be on systemic estrogen and vaginal estrogen. I will also say if you are not a candidate for systemic estrogen, you are almost always a candidate for vaginal estrogen. So even if you have had estrogen receptor positive breast cancer, most oncologists will allow vaginal estrogen so that you do not have to deal with uncomfortable vaginal symptoms. But we always check. So then there are different categories for who should be on hormone replacement therapy. So low-risk women are recently menopausal. They are active. They do not have hypertension. They don't smoke. Intermediate risk, maybe women with diabetes, who are smokers, obesity, who are not active in their lifestyle, cholesterol issues. And then high risk or potentially not candidates for estrogen replacement therapy are those with congenital heart disease, atherosclerotic disease, coronary artery disease, peripheral artery disease, someone who's had a blood clot previously, a stroke, if you have estrogen receptor positive breast cancer. So it is definitely important to tell your doctor your full history. I had someone the other day who I later learned had a PE but never told me. It's important to tell your doctor.
Just
A
to
pulmonary
make sure
embolus,
everybody knows
a
what
blood clot in your lung. So we can do you harm if we don't know your full history. So I have a lot of people who come and either leave that past medical history part blank or just put one or two things, and then I get in the chart and there is a lot in there. If you take a medicine for something, please write that down on the paper. It means you do have a medical problem. And even if it's controlled, we would still like you to write the medical problem down. But it's important to go and talk to your doctor about what risk category you fall in so we can make the best decision.
So I suspect we're going to have a lot of questions. So
Don't overwhelm me too much. I'll do my best.
where are we going to start, Michelle?
I had a complete hysterectomy at 29 years old. I'm 66 now, okay? So I have
Yes.
played the hormone game for 4 years.
Yeah.
One thing is when you go to your PCC, your regular doctor, what is the test to contest where my estrogen, where my testosterone, all of
Yes.
that levels are at?
Yes, so I have a lot of women who come in and say, like, I just don't feel right. I want to check my hormones. And it's kind of like a loaded request. But so we have lots of hormones. Thyroid is a hormone. I talked about FSH, follicle stimulating hormone. That's a hormone. Mainly what people are thinking when they ask that question is, where is my estrogen? Where is my progesterone? Where is my testosterone? So I almost never check estrogen. It vacillates in a day tremendously. And it doesn't tell me if you're menopausal or not. And it doesn't tell me that you're not going to have hot flashes. Like, you tell me you have symptoms of low estrogen, then I will treat them. And it's like $100 to $150. It's not going to do me any good to know where that level is. The only reason to check it is if I think you have a tumor that is secreting estrogen. That's the only time. Testosterone, if you are having low energy libido issues, then I will check it. Most women are going to have a level around 15. And it should only be replaced to 40 to 70. And again, only if you benefit from it in those first few months should you continue on it. It can affect your cardiovascular health long term. So FSH, I want to check. Your thyroid, I want to check because that can mess up your cycle as well. I will check your testosterone. Those are my main ones. The CRP, like they were saying earlier, that's recommended sometimes, it's not specific, so it really doesn't tell me as much information. But I really want to treat your symptoms. I want to treat your irregular bleeding. I want to treat your hot flashes, night sweats, brain fog, joint pain. So I don't need to know your estrogen level to do that.
Okay, I have a question over here.
I'm in the same boat as her. Had a hysterectomy very young, complete, and I have never taken hormone replacements at all. Haven't needed them. The doctor told me that the level of fat around my middle produced enough estrogen to keep me from needing them. And so I was like, okay, cool. I'll stay fat. No, but. The thing I do suffer with is the UTIs, and I have struggled with those for years. They think that it's because of an abdominal hernia repair. Is there a gynecologist in Lubbock?
Yes, we do have.
They want me to see one.
Okay.
And also, too, what type of estrogen, is it a cream that you give that helps that? Because Dr. Backdash was giving me some that he had created at one point.
So yes, it's an estradiol cream for the vagina. The systemic absorption of estrogen through the vaginal mucosa is very low, so it's a targeted treatment. So if you had other things like a history of a blood clot or stroke or breast cancer, that's why that is safe to use.
Okay.
And that is what reduces recurrent UTI in postmenopausal women. So that would be a good medication for you.
Okay.
We have had lots of changes in how we approach hormone replacement therapy in the last 50 years. So it is, I'm glad you made it through that period without having hormone replacement. Today, if we took your ovaries out at less than 35, we would have to have a really, really damn good reason to do it. Your ovaries are so important, and your all-cause mortality is higher if you remove your ovaries anytime before 60. So we like to keep them. But if you have them out, both of them out at any time before menopause, then you should be put on estrogen, and that should be discussed with your surgeon.
We have a question back here.
Yes, my question is about COPD. Is that reversible with exercise, or is that a permanent damage?
Holly or Haley?
So COPD, there's already damage in the lungs that has occurred. So COPD, just for people who don't, it's emphysema is another word for it. It's what happens to smokers most of the time, 95% of the time. And I'm not a lung doctor, so disclaimer here. But COPD is scarring in the lung. A lot of time the damage has been done. Now, if you're talking about COPD from smoking, if you stop smoking, it will not progress. Now, will you ever get back to your baseline of what you were? No. But, there are other medications that pulmonologists, lung doctors prescribe, inhalers and things like that to help treat it and help minimize symptoms and also minimize admissions to the hospital, that sorts of thing. The medications that they give for COPD do not affect your heart. A lot of our patients that I see in clinic have COPD because smokers tend to have, usually universally, they'll have some form of heart disease. But no, they do not, I actually encourage patients to take those medications because it helps the oxygenation of the bloodstream, which is good for the heart.
Okay, question over here.
Hello. I have a uterus, and I've also had breast cancer, and my body was also still producing estrogen. So now I'm on an estrogen blocker for 5 years, and I have 2 more years to go. And I have all of those symptoms that night sweats, feel like I'm 90 and have arthritis and all these things. So you haven't discussed about if you have the blocker of estrogen. You said if they need estrogen, but where would I be? They're blocking my estrogen.
Yes, and so if you have an estrogen receptor positive breast cancer and you benefit from an estrogen receptor blocker like aromatase, then you aren't a candidate for systemic estrogen. So you would fall into that category of considering medications like paroxetine, which is an antidepressant for hot flash management, clonidine or gabapentin, and there are a few others. You potentially, in conjunction with your oncologist, could be a candidate for vaginal estrogen for vaginal symptoms. But the systemic symptoms would need to be treated with one of those medications.
Okay, over here.
For your younger women who have postmenopause, is it best to see your PCP or an OB?
So there are ranges of what PCPs would like to focus on or specialize in. And so your PCP should always be a starting point where you can ask those questions and they could let you know how much they would like to manage it, or if they'd like to refer you to an OB-GYN. And of course, your gynecologist is an appropriate place. A lot of women only see a primary care. Some women only see their gynecologist. I think it's probably important to have check-ins with both. we recommend a breast exam every single year and a pelvic exam at least every other year if you are having 0 symptoms. So if you have a fantastic primary care that will do a breast exam and a pelvic exam on you, that's amazing. And you may only need a gynecologist for specialized questions, but they both potentially can manage that. Your gynecologist for sure.
Okay, over here.
There's a lot of conversation recently about HRT at all ages for women. What do you have to say about that?
So our studies, so we had this big study in the past where they started saying like estrogen is dangerous, it's gonna give you a stroke, we need to stop it. And so a lot of women missed out on menopause hormone replacement therapy. The same study has now been like re-examined and put into a different context and found that that really wasn't true. It was using a much older population outside of the menopause, 10 years post-menopause, and looking at the effect on them. So that's why we said, ideally, you're gonna start estrogen within 10 years of menopause or earlier, that if we wait till 10 years, then we are doing you harm by starting you on it. So are you gonna have benefit? Yes, your bones are gonna be happier, you're not gonna have hot flashes, but we have potentially increased your risk of stroke, which, like Dr. Houston said, 1 in 3 women will die of heart disease. So it's not an insignificant risk. Now, when you're going to the doctor and you're talking about risk benefits of medication, you are looking at yourself and your life and what is important to you. So y'all can have that individualized conversation about whether you can start a hormone or not.
Are there natural alternatives to hormone replacement therapy?
So there are some supplements that can help with perimenopausal symptoms. Like all things, they can have bad side effects or consequences. So like evening primrose can help with perimenopausal symptoms. That can lower your seizure threshold. So if you have seizures, then you want to be careful with that. Black cohosh can potentially help with menopausal symptoms, but if you're on a blood thinner, you can't take it. So, yes.
Could you tell us something about why the hairs grow on your chin? Is it because of medicine?
Yes.
Is it?
I'm sure that's a very isolated question that doesn't apply to anyone else.
No one else is curious.
I'm sure I'm the only one to have this,
Yeah.
but I need to know. I heard that it's caused by medicine or estrogen that we take, that if you haven't had the hairs growing up under your chin, and all of a sudden you start having them.
Yes, and so it is in some ways related to hormones, and in different times for different reasons. But so in younger women, like with PCOS, if you have higher levels of estrogen that are being converted into testosterone, then you're gonna have increased male pattern hair. We also see that as in menopause, as estrogen drops and perhaps testosterone is slightly more dominant, that you could have symptoms of coarse hair. So estrogen can potentially help with that to a degree. Testosterone is gonna make it worse, 1,000,000%. Spironolactone is a drug that you may be a candidate for as long as you have good, adequate birth control that can help reduce coarse hairs. You have to have good kidney function. So that's a prescription medication that can help with coarse hairs. And then there are some creams that are expensive.
Okay, one more question back here.
So if you start hormone replacement therapy within the 10 years, is this something that you have to continue for how long?
Well, I will say that I plan to continue it until I get one of those red flags that says I can't. I don't know, where am I looking? Where?
Right back here.
Okay, sorry. So the studies show that we are going to improve your bone mineral density, your skeletal muscle mass, potentially reduce dementia. They're going to help me not have night sweats and stabilize my mood. I mean, you're going to really have to like give me a really good reason to stop it. So my 79-year-old mother still uses her hormone replacement therapy and feels great. Now, if a contraindication came about, I'm going to kick her off of that. But so it's individualized. I think as long as it's safe, I would do it.
And I think also, like Dr. Henderson was saying, is that there's just been huge changes in these studies over the last 50 years, and the research is ongoing. I mean, throughout all of medicine, all of these studies, the big clinical trials were done predominantly in men. I mean, women were kind of left behind for a while. I think that mood and that has changed, and it's very well recognized just throughout all medical societies. And so I'm hopeful that these things catch up and we'll have better answers. I mean, is that a fair statement?
Yes, I mean, most of our medical screening and care and cutoffs and laboratory results, like you go to your doctor and you're like, all of these numbers were red. Like, why did they say it's normal? It's because they're based on a 35-year-old male. Like, so they probably don't pertain to you. And so they've looked and they've decided it looks good for you. Our DEXA screening is recommended at 65 because that's when men lose testosterone. Our bone mineral density builder is estrogen, and we lose that at 50. Like, why are we waiting till 65 to check? Because men. So it's different. And so we're changing that landscape. We are focusing on it, and now you are aware, so talk to your doctor and make sure you're getting the appropriate screening.
So Dr. Houston and Dr. Henderson, thank you all for being here. And to all of our panelists today, thank you. We hope this time that you've spent with us this morning has empowered you to prioritize your heart health. Small steps can lead to transformative changes. A shameless plug, we started earlier this year. It's called Health Her Way. It is a podcast that you can find on any of your podcast streaming sites. And some of our physicians that have been here today have been featured and will be featured in the future. But it is a podcast specifically for women by women. So we hope you will find that and tune in. They're usually under 30 minutes. You can listen to it with your weighted vest walking around your neighborhood. Or when you're having your Mediterranean lunch with a friend, you can, turn that on at the lunch table. But anyway, thank you all so much. We still have some tables outside. If you want some information about many of our Covenant Medical Group physicians, those are there. You can still get a blood pressure check. And anyway, thank you all for being here. Have a safe trip home.
Just really quickly, I know several of y'all had questions you didn't get answered. One resource that I highly trust and recommend is Dr. Mary Claire Haver on Instagram. She always posts her studies and has great advice. So if you had a question, she's a good resource to go to.